Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, it's the Public Health on Call Book Club. Our topic is war, specifically protecting healthcare workers during violent conflicts. Our author is Professor of the Practice, Len Rubenstein of the Johns Hopkins Bloomberg School of Public Health. This was a fascinating conversation. Let's listen. Len Rubenstein, thank you so much for joining us to talk about your new book called Perilous Medicine: The Struggle to Protect Healthcare from the Violence of War. And before we jump into the book, could you tell our listeners the work that you've done in this area in terms of protecting healthcare workers in times of war?
Yeah, so thank you for having me, Josh. It all started in the 1990s when I went to Bosnia after the war and learned about the horrors of the shelling of hospitals in Sarajevo, including a case where there were babies in a neonatal unit while the hospital was being shelled, and they had to get them out of there. And just a few minutes after they left, the place was destroyed. And they brought them next door, but without electricity, which had been shut down. 9 of the babies died. And that experience, learning that, led to a long series of investigations while I was at Physicians for Human Rights. And then since I came to Johns Hopkins a decade ago in Chechnya and Kosovo and Myanmar and Gaza and many other places to try to document the violations and then to really try to get a grasp on why they're taking place.
And as you did that, you also dug into the history of protecting healthcare workers during violence.
I did. And it's a fascinating history because it goes back so long ago. It goes back to 1859 in a very famous battle in northern Italy where a Swiss businessmen came across this terrible battle with wounded soldiers on the field dying of thirst and from their wounds with no one attending to them. And his name was Henri Dunant. And he was so appalled because there was no protection, no allowance of anyone to come attend to them because they could be shot. And that all resulted in the first Geneva Convention in 1864, which set the standard ever since, which says that people, all human beings, must be alleviated or must try to alleviate their unnecessary suffering, no matter who they are. And of course, that's an important ethic to medicine as well. And so the convention both allowed volunteers to attend to the wounded and then also to protect them, saying that combatants could not attack them, could not interfere with the wounded and sick, had to protect hospitals and houses where they were taken, could not punish the civilians who were housing them and treating them. And that was the beginning. And over the years, the principle was expanded beyond wounded soldiers to wounded civilians. It was expanded not only to outlawing attacks, but requiring affirmative steps to prevent harm.
Now, those steps, though, haven't always been followed. And in your book, you talk about many examples in the early years where, despite having the Geneva Convention, there were all kinds of atrocities. Could you talk a little bit about World War I and World War II in this regard?
Sure. People often talk about the attacks today as though there was some golden age of compliance with the rules, but there never was. In World War I, hospital ships were sunk. with torpedoes and in other ways. And the Red Cross reported dozens and dozens of violations that were never remedied. And in the war in Ethiopia by the Italians, hospitals were bombed, even though there were huge Red Crosses on their roofs. And then in the Second World War, cities were leveled through strategic bombing, where in Dresden and many other cities, and of course at Hiroshima and Nagasaki, the entire purpose was to obliterate the city. And unfortunately at the time, because it wasn't a direct intentional attack on a hospital, it was an intentional attack on a city, the convention didn't apply. And it took many years until 1977 for the conventions to be changed, modernized, so that these indiscriminate attacks became against the law.
Now,
and the worst place, I'm sorry, go ahead.
I was going to ask you about Vietnam, because that was right before those late 70s modifications and really brought to global consciousness the potential of atrocities in this area. Is that right?
Yes. On the one hand, the Vietnam War was characterized, again, by massive bombing and the massive use of napalm against civilian populations with no consideration of what it was going to do to people's health or to hospitals or the ability to survive. At the same time, the anti-war movement showed how horrific this bombing was. And along with one other major factor, which was the development of national liberation movements in the colonial world, contributed to re-examining the conventions and overcoming the resistance to outlawing attacks that were indiscriminate against civilians and, of course, hospitals.
So can you walk through this protocol that became more specific in terms of protecting healthcare workers within the Geneva Convention? What did it accomplish?
Yeah, the protocols, there were two of them in 1977, one for international conflicts and one for civil wars. And they did a few things, three really important things. Number one, they said there's a principle of distinction that you have to abide by, which is to distinguish between military and civilian objects. Second, and this gets to the question of collateral damage, any damage to civilian must be proportionate to the military objective sought. Now, that's a very tough standard, very difficult standard to apply because it's subject to interpretation. But it sent a very important message, which is that the idea that all collateral damage was acceptable was overturned. Third, for the first time, the convention specifically protected medical ethics. It said that no one may be punished for adhering to ethical obligations in healthcare. For example, the duty of impartiality, where medical personnel are supposed to treat people regardless of their affiliations or ethnicity, nationality, religion. So those three principles really transformed the Geneva Conventions and govern conduct today.
So let me ask you some specifics about that, because those are, pretty broad protections. Did they contemplate that, for example, militaries or insurgent groups might hide within hospitals or, be in an ambulance and try to, sneak up and do something?
They actually did, because it's very clear that the misuse of a medical facility or an ambulance to inflict harm on the enemy by storing weapons or firing from a health facility, it loses protection. That means it's a legitimate target. But even then, whoever attacks it has obligations so that the patients in the facility are not subject to undue harm. So you have to take precautions. You even have to warn before attacking a health facility, even if it's being misused.
And can a military go in and search a hospital if there's suspicion of a problem like that?
Yes, they can. It's a big problem. Searches are not prohibited, just as they are not prohibited in domestic law, where police can enter hospitals looking for a criminal or an alleged criminal. But it can't be conducted in a way that's unduly disruptive or dangerous. The problem, and with soldiers going to a hospital, they tend to go in with guns blazing, often shoot at staff or intimidate them or interfere with medical procedures. They're supposed to behave in an appropriate way. And unfortunately, that's honored and breached all too often.
So you have, in the 1860s, the Geneva Convention establishing the principle. It isn't until the 1970s when there's a lot more detail and kind of a thoughtful approach that balances, it attempts to balance these different, military and humanitarian priorities. How does it go after the 1970s, now that you have these more specific rules?
It's a very sad, tragic, unfortunate story where, just as in the past, the rules were flagrantly violated with impunity. It started in El Salvador, in Mozambique in the 1980s and 90s. And of course, there was Chechnya and Kosovo. In Kosovo, doctors were arrested and prosecuted for treating enemy soldiers. Then, of course, Syria, which is the worst case, where 600 hospitals have been bombed. And there was a strategy of attacking hospitals. And in Yemen, we see a classic example of indiscriminate bombing where the Saudi-led coalition made no effort to target properly, and they continued to receive military support from the United States and United Kingdom. So the record since 1970 is unfortunately not a lot better than it was beforehand. The only thing I can say is that Western powers have tended to stop bombing strategically. So we've seen instances, for example, in Afghanistan, where a wedding was bombed, or even an MSF hospital was mistakenly bombed. But there wasn't the kind of strategic bombing, the indiscriminate bombing that characterized the Second World War, Korea, and Vietnam.
In your book, you write about Israel and this issue related to different types of conflicts that have happened in and around Israel. And it's a somewhat complicated picture. Could you explain?
I focused on the history of the Israeli Defense Forces' treatment of ambulances over the last 20 years, because medical evacuation is so important, and it was a huge problem. And also, checkpoint delays are a major source of death and increasing severities of injuries because they're untreated around the world. And what's remarkable is, back when I was in the region in 2002 during the Second Intifada, the Israeli army had killed 5 Palestinian ambulance workers after clearing the ambulances for medical evacuation. And there was a big outcry about that. And as a result, there was a major reform, and Israel pretty much led the way in safely evacuating people in the midst of conflict. Unfortunately, over time, because the political pressures changed, the environment changed, attitudes changed, personnel changed. During the recent wars in Gaza, those reforms dissipated, and many people died in the Gaza fighting in the 4 wars in Gaza over the last 10 years, in which people couldn't be evacuated. Days went by before they were permitted. The ambulances were permitted to access. Israeli forces shot at ambulances and at medics, and we had tragic results.
So a difficult picture even after the reforms in the 1970s. In the book, you talk about the value of advocacy around this, with that period in Israel being one major example, but others. What do you see as the role of people in public health, medicine, or just interested in trying to change the practices to create this zone of protection around health and healthcare to reduce the loss of life in conflict?
It's absolutely essential. And the perfect illustration of that is that 5 years ago, the UN Security Council passed a very strong resolution designed to prevent attacks through changes in military operations, by investigating violations, by holding perpetrators to account. And in the 5 years since, countries have not complied with their obligations to implement this resolution. And I think the reason is there has been an absence of pressure to do so. And there's no more important community than the public health community to get involved. After all, we're concerned with public health and the well-being of populations, of developing health systems. These health systems around the world are being destroyed in war. And I think if the public health community, including ministers of health, but the broader community, became more active and there were more pressure, just as in other instances of human rights violations, I think it would make a difference. I also think the public health community has a role in solidarity. We need to support our colleagues who are struggling, and the book shows how much they struggle through a lot of stories of not only their vulnerability, but their moral distress in not being able to do the job they've been trained to do. So I think advocacy and solidarity is really our only hope to make a difference.
I think the book makes that case so clearly. And one of the things that I really like is that you tackle some reasons why people might be hesitant. And I want to conclude by asking you a couple of those. Well, one of them has to do with the idea that, well, sometimes war just has to be horrible, and maybe the war ends earlier if there are different, aggressive tactics taken. And so this is just what war is, and we shouldn't be, expecting war to be anything other than horrible. How do you respond to that critique?
Well, I think in two ways. First of all, the reason that Geneva Conventions have survived and been improved over 150 years is that governments recognized that even though war is terrible, it didn't have to be utter carnage to the civilian population. And there's no evidence that complying with the laws of war prolongs wars. A second dimension is that there's a competing theory of harm in war, which, Josh, you just alluded to. At the very time that Henri Dunant was promoting the principle of humanity, an American theorist named Francis Lieber was offering a justification that if you were fighting a just war and wanted to end it quickly, harm to civilians was legitimate. And he actually said that hospitals should be protected only as far as the contingencies of the fight allowed. And he actually wrote a code for the Union Army during the Civil War. And we saw how that played out in General Sherman's march through Georgia and South Carolina, where there was kind of rampant misbehavior by soldiers in destruction of property and lives. And it's so important. And that rationale or rationalization still exists today. Why soldiers and armies think you shouldn't treat enemies. We have to go back to first principles. And those principles are really very much more embraced than this idea of winning a just war quickly.
I want to ask you about one other, which is the idea that, well, some of these doctors and nurses, they're really sympathetic toward the enemy, whoever the enemy might be. And so we shouldn't think of them as doctors and nurses. We should think of them as believing in whatever the particular issue is and maybe on a different side than the ones that we're on. How do you respond to that?
Most doctors, I'm not a physician, but when I talk to doctors and nurses, they say what an MSF doctor said, that the judgment is for courts, not for doctors. A symposium of Israeli and other bioethicists concluded the same thing, that the obligation in medicine and public health is to end needless suffering. And in the book, I tell the story of one of the bombers in the Boston Marathon case, one of the Tsarnaev brothers, and he was very seriously injured. He was brought to hospital in Boston, and the surgeon was interviewed about why he saved the young man's life. And he said, "This is what we do. Doctors, the medical community, public health, it's not about making judgments about people before treating them. You can make the judgments, but not by denying them care."
There's another idea that you respond to in the book, which is the idea that, maybe we shouldn't care so much about doctors and nurses who themselves have strong political beliefs and may actually be sympathetic to the people that we consider to be enemies in whatever conflict we're talking about. And so, maybe these rules don't quite have the same applicability to someone who's, in a sense, already chosen sides, even though they are also a doctor and a nurse. How do you respond to that?
It's unfortunately a major misconception. The obligation ethically is to be impartial, but we can't expect, and the law doesn't expect, a physician or a nurse to be politically neutral. In fact, many can't be. A military doctor can't be neutral. A Syrian who is being assaulted by the Assad regime can't be neutral, but they can still be doing their job. They can still do their job appropriately. And their political views has nothing to do with their entitlement to protection.
Well, Len Rubenstein, thank you so much for joining me on the podcast. It's really a tremendous book, Perilous Medicine, The Struggle to Protect Healthcare from the Violence of War.
Thank you. It's been a pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.